Okay friends, so this gets us to a second category of lung diseases and an important one, that is obstructive lung diseases. Starting with obstructive lung diseases, their common feature is that it is associated with increase in resistance to airflow. It is associated with increase in resistance to airflow. This is the common feature. Next point, there are four main obstructive lung diseases. We'll do each one of these one by one. They are emphysema, they are emphysema, chronic bronchitis, emphysema, chronic bronchitis, asthma, and bronchiectasis. Asthma and bronchiectasis. So there are four obstructive lung diseases which are emphysema, chronic bronchitis, asthma and bronchiectasis. Now before we actually start with each one of these, let us have a look at another term, that is COPD. That is COPD, chronic obstructive pulmonary disorder. COPD, which is emphysema plus chronic bronchitis, which is emphysema plus chronic bronchitis. This is chronic obstructive pulmonary disorder. Chronic obstructive pulmonary disorder, COPD. You will be doing these terms much more in detail when you enter medicine. Now, before we go further, let us have a look at salient features of each. Emphysema. Emphysema is associated with dilatation of the alveoli. Atelectasis was collapse. Atelectasis was collapse. Emphysema is dilatation. Chronic bronchitis, excessive sputum production. Asthma is the allergic response, and bronchiectasis is again dilatation. So starting with emphysema, it is associated with dilatation. Okay, let us go point wise and then we'll come back to the top. Emphysema. First point, reversible or irreversible. Emphysema, this is irreversible dilatation. This is irreversible. First point, it is irreversible dilatation distal to terminal bronchiole. Irreversible dilatation distal to terminal bronchiole. Distal to terminal bronchiole is an acinus. Distal to terminal bronchiole is an acinus. So irreversible dilatation distal to terminal bronchiole, that is of the respiratory bronchiole, alveolar duct and alveolar sac. That is emphysema. Next point, my question to you is, if it is associated with dilatation, that means there is more air in the alveoli, then what is the problem? The problem is that alveoli should expand and collapse. Expand, collapse. Here expansion is there, but the collapse is not proper. So that is why these patients are called as pink puffers. They are pink because they have air, but they are breathless. They are puffing because the recoil capacity of the alveoli is not proper. So let us add this at the top only. Emphysema is pink puffers versus chronic bronchitis, which is blue bloaters, versus chronic bronchitis, which is blue bloaters. Next point, I'm sure that once you have gone to the wards and seen these patients, you will never confuse between the two. Just for the third and fourth sem, B for bronchitis, B for blue bloaters. Next point, coming back to emphysema. Emphysema is of four main types, that is types of emphysema. Let us again make a flowchart. Emphysema is of four types: centriacinar, panacinar, paraseptal and irregular. It is of four types, that is centriacinar emphysema, panacinar emphysema, panacinar, paraseptal emphysema and irregular emphysema. and irregular. So it is of four types. First point, most common emphysema. 1 2 3 4. Most common centriacina. नहीं बच्चे, irregular. Most common irregular. When is it detected? Neonate, infant, children after death. When? It is an autopsy finding. It is an autopsy finding. Autopsy finding means, is it clinically significant or non-significant? It is clinically non-significant. Clinically non-significant. So the most common emphysema is irregular type. It is an autopsy finding and is clinically non-significant in nature. Lastly, it is seen in any part of the lung. It is seen in any part of the lung. This is irregular emphysema. Next question. Most common clinically significant emphysema. Most common clinically significant centriacinar. Most common clinically significant emphysema centriacinar. How much? More than 95%. So more than 95% patients going to the doctor have centriacinar. So see the language of the question properly. Next point, which emphysema has the strongest association with smoking? Centriacinar. Centriacinar. So the main risk factor for centriacinar emphysema is smoking, and it is the most clinically significant. Next, location. Location. When we inhale air, more air goes to the apex of the lung. So when a patient is smoking, more smoke goes to apex. That is apical and posterior segments. Apical and posterior segments of upper lobe of the lung. Apical and posterior segments of upper lobe of the lung. This is centriacinar emphysema. Next, panacinar. Panacinar emphysema, this is associated with which disease? It is associated with alpha 1 antitrypsin deficiency. Extremely important. Associated with alpha 1 antitrypsin deficiency. Next point, location. Location. Easy to remember. Panacinar. The whole acinus is involved, so it comes and settles down. Location. Lower lobes of the lung. Location. Lower lobes of the lung. That is panacinar emphysema. Next is paraseptal. Just 1 2 lines with this. Paraseptal emphysema. It is present next to the septa. Paraseptal. So this can cause, just one line. This can cause spontaneous pneumothorax. This can cause spontaneous pneumothorax. It can cause spontaneous pneumothorax. This is emphysema. So we saw the four main types of emphysema, that is centriacinar, panacinar, paraseptal, and irregular type. Next, I guess it's looking beautiful with all the four different colors and stuff, but these are the types of emphysema. Next point. These were the four main types. We'll come to alpha 1 antitrypsin deficiency in just 2 minutes. This gets us to the other types of emphysema. These were the four main types. Next is other types. Other types of emphysema. Other types of emphysema. They are starting with compensatory hyperinflation. There are three other types, starting with compensatory hyperinflation. Compensatory compensatory hyperinflation. The name tells you everything. Hyperinflation is taking place as a compensatory response. Compensatory hyperinflation. First point, this is expansion of residual lung. expansion of residual lung after surgical removal of diseased lung. After the surgical removal of diseased lung. The name told you that this is a compensatory response. Why is the compensation needed? Because we have surgically removed the diseased lung. That was obvious. Important point to be noted here is microscopically. Compensatory hyperinflation, there is dilatation of alveoli, there is dilatation of alveoli, but but there is no destruction of septal walls. No destruction of septal walls. This is important. When we will see what emphysema looks like microscopically, I'll show you that the septal walls are destroyed, except in compensatory hyperinflation. Except in compensatory hyperinflation. This is a compensatory response, so there is no destruction of septal walls. Next, the next type of emphysema. The next type is obstructive overinflation. Next is obstructive overinflation. Obstructive overinflation, again because of partial obstruction of the airway. If this is the airway, partial obstruction, so the air can enter, leading to dilatation of distal turret, but it cannot come out. So it is associated with subtotal obstruction. Associated with subtotal obstruction, which in turn leads to entrapment, of air and expansion of lungs, which leads to entrapment of air and expansion of lungs. Entrapment of air and expansion of lungs. Next point. This is a life-threatening emergency. This is a life-threatening emergency. And why is subtotal obstruction occurring? Either because of a foreign body or a tumor. Either because of a foreign body or a tumor. Now, point to be noted here is total obstruction. Put a line on the side and then write total obstruction of airways. Total obstruction of airways was associated with atelectasis, that is collapse of the lung, whereas partial obstruction of the airways is associated with emphysema. And very important difference, Next point. The last type of emphysema is bullous emphysema. The last type is bullous emphysema. Bullous emphysema. Bullous emphysema, this is localized emphysema in relation to old TB scar. I'll write it for you. This is local in relation to old TB scar. In relation to old TB scar. There was an old TB scar which was associated with localized emphysema, that is bullous emphysema. These bullae can rupture. It can be associated with rupture of bullae, in turn leading to pneumothorax. Very obvious, if the bulla is ruptured, there is entry of air into the thoracic cavity, pneumothorax. Lastly, location. The most common location is apex of the lung. Most common is apex of the lung. And when we'll do TB in about 1.5 hours, we will also see that apex of the lung as such is the most common location for secondary TB. These are the types of emphysema. These are the types of emphysema. Next point. Next point. Which emphysema was associated with which disease? Pan-acidic emphysema associated with alpha 1 antitrypsin deficiency. So this gets us to alpha 1 antitrypsin deficiency. This gets us to alpha 1 antitrypsin deficiency. First point, the name tells you everything. Acha, before we go further, first tell me the inheritance pattern. This is autosomal recessive, alpha 1 antitrypsin deficiency, autosomal recessive. Which chromosome? Present on chromosome 14. Very commonly asked. Cystic fibrosis, cystic fibrosis, chromosome 7. Cystic fibrosis, chromosome 7. Alpha 1 antitrypsin deficiency, chromosome 14. Next point. Next point. Alpha 1 antitrypsin. Let us start with the pathogenesis. Let us start with pathogenesis. Tobacco, tobacco or irritant gases. Tobacco, smoke or irritant gases or irritant gases lead to the formation of reactive oxygen species, lead to the formation of reactive oxygen species or free radicals, which in turn leads to activation of macrophages, which in turn leads to activation of macrophages and neutrophils. Neutrophils contain granules, release of cytoplasmic granules, release of cytoplasmic granules. Cytoplasmic granules contain elastases. It contains elastases, proteases. We saw this in the granules of inflammatory cells and cell injury. Release of cytoplasmic granules which contains elastases, proteases, which in turn leads to lung damage and emphysema, which in turn leads to lung damage and emphysema. This is the pathway. Now, by this funda, we live in a very polluted environment. So, I mean, though we are not smoking, and as such, I'm again stressing this. Having alcohol is still okay, but which is smoking is an absolute no. Those of you who do so, the carry home message, whether you understand anything in lungs or not, whether you remember anything in lungs or not concerned. If just your carry home message is do not smoke, I guess my topic in lungs would be comfortable, because this topic will just be with you for the next 1 year or 2 3 years till you clear PG, and then you'll go to your respective branches. But if you stop smoking today, that will be with you lifelong. So please do so. Please do so. So by this funda, all of us should be patients of emphysema. What is the role of antitrypsin? Alpha 1 antitrypsin. Antitrypsin, it is an anti-elastase. Antitrypsin, trypsin is elastase or protease, so it is anti-elastase or anti-protease. It is anti-elastase or anti-protease, which reduces or stops the action of neutrophilic granules, which stops the action of neutrophilic granules. So if alpha 1 antitrypsin is deficient, if this is deficient, the action of neutrophilic granules increases, in turn leading to emphysema. This is alpha 1 antitrypsin deficiency. This is the pathogenesis of alpha 1 antitrypsin deficiency. Next point. Next point. Diseases associated. Next point. Diseases associated with alpha 1 antitrypsin deficiency. Diseases associated. I am copy pasting the same slide from lungs, from liver. We did alpha 1 antitrypsin and metabolic disease of the liver also. So, starting with lungs. In the lungs, alpha 1 antitrypsin is associated with pan-acinar emphysema. Pan-acinar emphysema. Next, it is also associated with venous granulomatosis, venous granulomatosis, and venous granulomatosis, and bronchiectasis, and bronchiectasis. Next, it is associated with subcutaneous panniculitis. This is the same slide, no difference. Panniculitis, itis is inflammation. Panniculitis is inflammation of fat. So, inflammation of fat in the subcutaneous tissue. Inflammation of fat in subcutaneous tissue. Subcutaneous panniculitis. And lastly, it is also associated with neonatal hepatitis. Also associated with neonatal hepatitis. This is alpha 1 antitrypsin deficiency. Next point, this gets us to genotype phenotype correlation. This gets us to genotype phenotype correlation. Genotype phenotype correlation in alpha 1 antitrypsin deficiency. Genotype phenotype correlation. Genotype is the genetic structure, that is, what is the genetic structure, the genes, whereas phenotype are the clinical features. Phenotype are the clinical features. First point, inheritance pattern. What is the inheritance pattern of alpha 1 antitrypsin deficiency? Autosomal recessive. Fair enough. But a special subtype of autosomal recessive, that is autosomal codominant allele expression. Autosomal codominant allele expression. Autosomal codominant means that, see, each gene locus has two alleles. Both the alleles are doing their own function. There is no relation between the two. Which other thing in the body is autosomal codominant? ABO blood grouping. Remember, if a patient is AB blood group, it is neither A nor B, it is AB. So, autosomal codominant. Next point, the wild type allele, the wild type allele, wild means normal, yeah, abnormal, normal. Please do not think that civilization is normal, wild is abnormal. नहीं बच्चे, wild मतलब normal. Wild type allele is M type. Next, moderate reduction in activity. Moderate reduction in activity. Moderate reduction means 60% of the activity is by S type. Moderate reduction, that is 60% of the activity is by the S type, by S type. 10% of the activity, 10% of the activity is by Z or Z type, and no activity is null phenotype. No activity is null genotype. And the phenotype is the null genotype. Easy to remember. Wild type or normal is M. Moderate reduction is S. My name is Sushant. I always remember it as I'm a moderately nice guy. I'm neither very nice nor very bad. Moderate reduction S. 10% Z. No activity, null genotype. So, if I have to write the increasing severity of the disease, if I have to write the increasing severity of the disease, it will be MM, which is normal, followed by MS, SS, MZ, ZZ, and the null type. This is increasing severity of the disease. This is increasing severity of the disease. See, M is 100, MM 100, 200, MS 160, 160, SS 60, 60, 120, MZ 110, 110, 10, 10, 20, null is no phenotype. So this is increasing severity of the disease, and this is genotype phenotype correlation. This finishes alpha 1 antitrypsin deficiency. This finishes your first main obstructive lung disease, that is emphysema. This was your main topic. Others are much smaller. This gets us to our next obstructive lung disease, that is chronic bronchitis. This gets us to our next obstructive lung disease, that is chronic bronchitis. Chronic bronchitis. Just one word with this. First point, when I say chronic bronchitis, what comes to your mind? Excessive sputum production. Chronic bronchitis. This is excessive sputum production. Excessive sputum for at least 3 months. At least 3 months for 2 consecutive years. For 2 consecutive years. This is chronic bronchitis. Excessive sputum at least 3 months for 2 consecutive years. Next point. Next point. Now, microscopically, I need not even say this that the initiating event is smoke. That is very obvious. Microscopically, if there is lot of sputum, so it is associated with mucus gland hyperplasia. It is associated with mucus gland hyperplasia. The mucus cells, they increase in number. Mucus gland hyperplasia. It is also associated with goblet cell hyperplasia. Goblet cell hyperplasia and chronic inflammation. And chronic inflammation. Very obvious. I have not increased your knowledge by writing this. This was common sense. What we have written till now is time pass. The only important point to be read in chronic bronchitis is mucus gland hyperplasia is demonstrated as Reed's index. This is important. Reed's index. Reed's index more than 0.4 is suggestive of chronic bronchitis. What do we mean by Reed's index? Reed's index is the ratio of thickness of mucus gland layer. Ratio of thickness of mucus gland layer. Thickness of mucus gland layer to the thickness of wall to the thickness of wall between mucosa and cartilage. Thickness of wall between mucosa and cartilage. Very, very important. Reed's index more than 0.4. Let us see what we mean by this. Thickness of mucus gland layer to the thickness of wall between mucosa and cartilage. See, what is the normal epithelium of the respiratory tract? Ciliated columnar, pseudostratified ciliated columnar. So if this is the epithelium, this is the basement membrane, this is the epithelium, with all the nuclei. I am not drawing the nuclei, with all the nuclei. Epithelium, wait, let me label this. This is the epithelium, this is basement membrane. Below that is the submucosa, that is, it has the mucus glands. All these are the mucus glands which are undergoing hyperplasia. There is an increase in number of mucus glands. Increase in number of mucus glands. Below the mucus glands is cartilage. This is mucus glands. Below the mucus glands, below the mucus glands is the cartilage. Is the cartilage. I'm drawing it in blue because from histology you very well know it has a slightly bluish tinge with all the nuclei. This is cartilage. So Reed's index. So Reed's index. Reed's index is the ratio of, just a sec. Reed's index is the ratio of mucus gland layer, that is this one, ratio of mucus gland layer to the thickness of wall between mucosa and cartilage, that is this. So Reed's index is Reed's index is A divided by B, ratio of mucus gland layer to the thickness of wall between mucosa and cartilage. A divided by B. Mucus gland hyperplasia takes place, so Reed's index is more than 0.4 in chronic bronchitis. In chronic bronchitis. Next point. Next, this gets us to a next obstructive lung disease, that is asthma. This gets us to a next obstructive lung disease, that is asthma. Asthma, we have done this very well in immunity, general path immunity. Let us just see the features of this. You know this now, you know this well by now. Asthma, it is associated with type 1 hypersensitivity, most common immunoglobulin, IgE, main cells, mast cells, and eosinophils. If you have to mark one, you will mark mast cell, main cell, mast cells, and eosinophils. Stain for mast cells, toluidine blue. Stain for mast cells, toluidine blue. Main cytokines associated, interleukin 4, 5, and 13. Main cytokines, interleukin 4, 5, and 13. Most potent activator of eosinophils. Most potent activator of eosinophils, interleukin 5. Most potent activator of eosinophils, interleukin 5. Interleukin 5. Which TH response is this? It is TH, T helper cell 2. TH2 response. T helper cell 2 response. You already knew these points. Nothing new. We have covered all this in immunity. What is important now is microscopy. What is important is, okay, before we go to the microscopy, tell me one, two more points. Genetics. Genetics. It is associated with chromosome 5 polymorphisms. Long arm, short arm, long arm. 5q associated with chromosome 5q polymorphisms. Associated with 5q polymorphisms. Next point, microscopy. Microscopy. Microscopically, asthma shows us three features, which are the presence of Kirschmann spirals. Microscopically, it shows three features, which are Kirschmann spirals. Kirschmann spirals, these are thick tenacious mucus plugs. Thick tenacious mucus plugs present in sputum sample. Thick mucus plugs present in sputum sample. That is, there is a thick mucus plug. It is a thick mucus plug present in background of mucus. Kirschmann spirals. Next, the next microscopic feature is it is associated with charcoal laden crystals. Charcoal laden crystals. Charcoal laden crystals. These are composed of charcoal laden crystals. These are composed of eosinophilic protein. Composed of eosinophilic protein. Eosinophilic protein called as galectin 10. Eosinophilic protein called as galectin 10. Charcoal laden crystals. And the last microscopy is it is also composed of Criolla bodies. The last microscopic feature is Criolla bodies. Criolla bodies, these are thick, these are collections of, these are ciliated columnar epithelial cells. These are ciliated columnar epithelial cells. Ciliated columnar epithelial cells which are slowed from bronchial mucosa. Slowed from bronchial mucosa. Slowed from bronchial mucosa and present in sputum. And present in sputum, that is Criolla bodies. So we have seen three microscopic features of asthma: charcoal laden crystals, which were composed of eosinophilic protein galectin 10, Kirschmann spirals, which were the thick tenacious mucus plugs, and Criolla bodies, that is slowed columnar epithelial cells present in sputum sample. Done. So this finishes asthma. Before we go to the last obstructive lung disease, that is bronchiectasis, let us have a quick recap. There were four obstructive lung diseases: emphysema, chronic bronchitis, asthma, bronchiectasis. Emphysema was of four common types: centriacinar, panacinar, paraseptal, and irregular. The other types were bullous hyperinflation, compensatory hyperinflation, and stuff. Not much concern, the four common types. Next, chronic bronchitis. Excessive sputum for more than 3 months for 2 consecutive years. Which index? Reed's index. Next, asthma. Asthma microscopically shows us three features which we have already seen. And the last is bronchiectasis. The last obstructive lung disease is bronchiectasis. Bronchiectasis. Bronchiectasis, this is permanent dilatation. This is permanent dilatation of bronchi and bronchioles. Permanent dilatation of bronchi and bronchioles. So what is the difference between emphysema and bronchiectasis? Emphysema is distal to terminal bronchiole, whereas bronchiectasis is of the bronchi and bronchioles. Next point, causes. Causes. Firstly, it can be idiopathic. It can be idiopathic, that is the cause is unknown. Next, bronchiectasis is mostly a medicine topic. As a pathologist, I am not much concerned with it. Next, it can be associated with numerous infections of the lung. You can name any infection, it can be associated with bronchiectasis. That is, it can be bacterial, viral, fungal, mycoplasma, anything. Important is congenital. Congenital or hereditary conditions. Congenital or hereditary. This is the only word I am concerned with in bronchiectasis. Congenital. And the congenital disease associated with bronchiectasis is Cartagena's syndrome. Is Cartagena's syndrome. Cartagena's syndrome. We did this in anatomy also in first year. Cartagena's syndrome. Cartagena's syndrome is primary ciliary dyskinesia. It is primary ciliary dyskinesia. Primary ciliary dyskinesia means there is problem in the motility of cilia primarily. Primary ciliary dyskinesia. So it has the classical triad. It is a triad of situs inversus. Situs inversus is left is right, right is left. Heart is present on right hand side, spleen is present on right hand side, liver is present on left. Situs inversus, bronchiectasis, bronchiectasis, and sinusitis. And sinusitis because the ciliary movement is not proper. So, Cartagena's syndrome, it is a triad of situs inversus, bronchiectasis, and sinusitis. Next point, it is also associated with male infertility. Associated with male infertility. This is not a part of triad, but Cartagena's is associated with male infertility. This is bronchiectasis. This is bronchiectasis. So this takes care of your theory portion for obstructive lung diseases. Next, before we go further, let us see what it looks like microscopically. Starting with the first image, let us have a quick recap. Diagnosis. This we have already seen is a nice normal lung. Identify the alveoli. These are the thin walled alveolar septa with air inside them. Nice normal lung. Differentiate it from emphysema. How do we know this is lung? By the presence of normal alveoli. These are all the normal alveoli. You're able to see nice thin walled septa with irreversible dilatation of the acinus. This is emphysema. This is emphysema. Please note, emphysema microscopically is also associated with destruction of septal wall. See, the septal wall is destroyed. This is not needed for you to make a diagnosis. I'm just showing it to you. Except which emphysema? Compensatory hyperinflation. That was microscopically not associated with destruction of septal wall. Next, diagnosis. This is a spotter. Diagnosis. What you have here are thick tenacious plugs. Thick tenacious mucus plugs. Kirschmann spirals. Thick tenacious mucus plugs in sputum sample. Kirschmann spirals. Just curious, why is it red? Eosinophilic protein. नहीं बच्चे, नहीं. A patient coming to you with red sputum, what is the first thing you will think of? Hemoptysis, blood in sputum. You are able to see the presence of RBCs in the background. Are you able to make them out? These are all RBCs, blood in sputum. Next, diagnosis. Diagnosis. Again a spotter. You have the presence of large arrows even on the crystals. Charcot Leyden crystals. Charcot Leyden crystals composed of which eosinophilic protein? Galectin 10. Composed of galectin 10. Next point, what are these cells? They can also be asked with an arrow. What are these? These are large cells with something black inside them. We live in a polluted environment. What does pollution have? Carbon. So these are carbon laden macrophages. All these are carbon laden macrophages. These tell us that it is a sputum slide, the presence of carbon laden macrophages. Next, I am telling you that this is sputum. Diagnosis. What we have here are collections of ciliated columnar cells which are present, which are slowed from the mucosa, and present aggregated in sputum sample, making this as Criolla bodies, making this as Criolla bodies, that is slowed columnar epithelial cells present in sputum. So we have seen, so let's have a quick recap. We finished obstructive lung diseases, 4 types: emphysema, chronic bronchitis, asthma, and bronchiectasis, along with their microscopies.